Today on Derm School, we are going to look at two very common conditions, acne and rosacea. For acne, we are going to look at the introduction, pathogenesis, clinical manifestation, syndromes of forms, investigations, and treatment, while for rosacea, we are looking at introduction, staging, clinical manifestation, and management. So first up, acne. Acne is a disease in which you have inflammation of the pilosebaceous units. Common areas affected are the face and trunk, and rarely the buttocks, and it is more frequent in adolescents. In acne, you find lesions such as comedones, papulopustules, nodules, and cysts, and these often result in pitted, depressed, or hypertrophic scars. So looking at the pathogenesis of acne, there are a few things that occur. Have inflammation, accumulation of Propionibacterium, or what is now known as Cutibacterium acnes, hyperkeratinization, as well as increased sebum production. So these four factors all play a role in the pathogenesis of acne. So you can see here it starts with a microcomedone, in which you have increased keratin production and excess sebum secretion. These causes the cells lining the hair follicle, known as corneocytes, to clump together. Later on in the comedone, you have closed as well as open type, and you can see here that the shed corneocytes and sebum accumulate and form a plaque that causes a closed comedone, also known as whitehead, or an open comedone, blackhead. Next, with Cutibacterium acnes proliferation, inflammation occurs, and you get papules as well as pustules. And finally, more severe lesions will be cysts or nodules in which there's marked inflammatory response and rupture of the follicular wall, and this may lead to scarring. So you can divide the types of acne lesions into two major types, which are the non-inflammatory lesions as well as the inflammatory lesions. So for non-inflammatory lesions, basically these are comedones, whether they're open comedones or blackheads, as you can see in the picture, or closed comedones, also known as whiteheads. For inflammatory lesions, you have papules or papulopustules, nodules, as well as cysts. Other lesions that can be seen include sinuses, scars, as well as seborrhea. This is the Comprehensive Acne Severity Scale, or the CAS. Grade 0 is clear, in which you have no lesions to barely noticeable ones, very few scattered comedones and papules. 1 is almost clear, which means it's hardly visible from 2.56 meters away, and the patient has a few scattered comedones, few small papules, and very few pustules. For grade 2, this is mild, in which it's easily recognizable, but less than half the affected area is involved, with many comedones, papules, and pustules. Moderate, that's a grade of 3, in which you have more than half of the affected area involved, with numerous comedones, papules, and pustules. 4 is severe, in which the entire area is involved, covered with comedones, numerous pustules and papules, a few nodules and cysts, whereas 5 is very severe, with highly inflammatory acne covering the affected area with nodules and cysts present. In terms of the types of acne scars, you can have hypertrophic scars or keloid scars. The other category of scars are atrophic scars, and you can see there are three main types. The ice pick scars, which are deep and narrow, less than 2 millimeter, sharply demarcated tracts that extend to the deep dermis. Box scar, which are either shallow or deep, round to oval depressions with sharply demarcated vertical edges and flat bottoms, as well as rolling scars, which are wide, more than 4 to 5 millimeter, shallow or deep depression with gently sloped edges, and these are caused by dermal tethering. Acne conglobata is a condition in which the patient has severe cystic acne, affecting the trunk more than the face, with coalescing nodules, cysts, abscesses, and ulceration. Acne fulminans often affects teenage boys with acute onset. In acne fulminans, there is severe cystic acne with suppuration and ulceration. Patients can also have malaise, fatigue, fever, arthralgias, as well as leukocytosis and elevated ESR. Occupational acne can be caused by tar derivatives, cutting oils, as well as chlorinated hydrocarbons. Chloracne is attributed to chlorinated aromatic hydrocarbons. These can be found in electrical conductors, insecticides, herbicides, industrial accidents, as well as dioxin poisoning. Sappho syndrome refers to synovitis, acne fulminans, Hamoplantar pustulosis, hidradenitis suppurativa, hyperkeratosis, as well as osteitis. While Papa syndrome refers to sterile pyogenic arthritis with pyoderma gangrenosum and acne. Investigations for acne. If endocrine disorder is suspected, such as hyperandrogenism and PCOS, consider the following tests: estrogen, progesterone, free and total testosterone, FSH, LH, SHBG, androstenedione, and DHEAS, as well as prolactin, cortisol, growth hormone, and IGF. In recalcitrant acne, you have to exclude congenital adrenal hyperplasia. And before starting isotretinoin, remember to send off the lipid panel as well as liver function tests. The aims of treatment of acne are to correct altered pattern of follicular keratinization, decrease sebaceous gland activity, decrease follicular bacterial population, particularly C. acnes, as well as exert an anti-inflammatory effect. So this is the algorithm on the management of acne vulgaris from the Malaysian CPG. You can divide it either into mild, moderate, or severe. For mild lesions, which are predominantly non-inflammatory lesions, you can use topical retinoids. Predominantly inflammatory lesion, you would want to use topical benzoyl peroxide as well. If there's no improvement after 3 months, you may have to combine any of the 2 topical agents. And this treatment algorithm holds true for moderate acne as well. So benzoyl peroxide is preferred, but as well as retinoids, topical antibiotics, azelaic acid, as well as salicylic acid. If there's no further improvement after 3 months, you might have to add on an oral antibiotic such as doxycycline, tetracycline, or erythromycin. And if there's no further improvement after another 3 months with the oral antibiotic, you might require referral to the dermatologist for isotretinoin with or without physical therapy. For patients with severe disease, you would consider isotretinoin straight away. Maintenance treatment with topical retinoids or topical benzoyl peroxide is still required once the acne is under control. Topical treatment options include benzoyl peroxide 2.5, 5, and 10%, retinoids such as tretinoin, adapalene, tazarotene, and trifarotene, antibiotics such as clindamycin, erythromycin, and minocycline, azelaic acid, salicylic acid, dapsone, sulfur 1 to 10%, as well as clascoterone. Systemic treatment options: oral antibiotics, including the tetracycline class, such as doxycycline, tetracycline, minocycline, lemmicycline, and sarecycline. Macrolides, such as erythromycin or azithromycin, as well as trimethoprim sulfamethoxazole. However, this last option, you have to be aware of the risk of severe cutaneous adverse drug reactions. Next, severe disease, you can also use oral isotretinoin, also for moderate disease that does not respond to antibiotics. Oral hormonal therapy includes combined oral contraceptives as well as spironolactone, and metformin can be used as an adjuvant treatment. Isotretinoin is teratogenic. You need to have strict contraception while on isotretinoin and 1 month after discontinuation. In women of childbearing age, you would want to check for a pregnancy test prior to starting isotretinoin, and this is to be monitored regularly as well. You also have to inform the patients not to donate blood, and patients always have to be counseled about this issue. Other systemic treatments for severe acne: you can consider adjunctive systemic glucocorticoids in patients with severe acne conglobata, acne fulminans, as well as Sappho and Papa syndromes. Physical treatment options include intralesional corticosteroids, which are useful for nodules and cysts, comedone extraction, as well as chemical peels, including salicylic acid, glycolic acid, Jester's solution, trichloroacetic acid, azelaic acid, and combination peels. Energy-based devices. These can range from light-based therapy, such as using visible light sources like blue light or red light, photodynamic therapy, or intense pulse light. Certain types of lasers may also be offered, such as the 1550 nanometer erbium glass laser, 1064 nanometer Nd:YAG, the pulse dye laser, as well as the 1550 nanometer non-ablative fractional laser. And radiofrequency may also be an option. Cosmeceuticals. Cleansers that can be recommended include antiseptic washes and cleansers containing benzoyl peroxide, alpha-hydroxy acids, as well as salicylic acids. Other cosmeceuticals include the use of sonic cleansing devices. However, there's not much evidence for that. Moisturizers, sunscreen, as well as hydrocolloid acne patches. These are a few active ingredients that you can find in cosmeceuticals that can help with acne. Corneolytics such as retinaldehyde and retinol, AHAs such as glycolic acid, beta-hydroxy acids such as salicylic acid, as well as polyhydroxy acids such as lactobacillic acid and gluconolactone. Next, you can have sebum controllers with anti-inflammatory properties, and an example is nicotinamide. Antibacterial agents, for instance, tyrothricin, tea tree oil, aloe vera, propolis, glycocalcone A, and cedar, as well as antioxidants including green tea extracts, whether topical and oral, as well as vitamin C. We now move on and look at rosacea. Rosacea is a common chronic inflammatory acneiform disorder of the facial pilosebaceous units. There is increased reactivity of capillaries, leading to flushing and telangiectasia. And rosacea may result in sebaceous hyperplasia, edema, or fibrosis, leading to rubbery thickening of the nose, cheeks, forehead, and chin. It commonly affects people aged 30 to 50 years, predominantly in females. However, rhinophyma is more often found in males. This is the staging of rosacea. All right, for rosacea diastasis, these are patients with episodic erythema, namely they are flushing and blushing. Now in stage 1, you have persistent erythema with telangiectasias. Stage 2, persistent erythema, telangiectasias, papules, and tiny pustules. In stage 3, there is persistent deep erythema, dense telangiectasias, papules, pustules, and nodules. Rarely, patients have persistent solid edema on the central face. In terms of history, patients report episodic reddening of the face or flushing in response to hot liquids, spicy food, alcohol, exposure to sun, and heat. It can last for days, weeks, or even months. This is a patient with erythematotelangiectatic rosacea, while this is another patient with papulopustular rosacea. This is a patient with rhinophyma affecting the nose. Ocular rosacea can also occur in which there's eye involvement with chronic blepharitis, conjunctivitis, episcleritis, rosacea keratitis, as well as corneal ulcers. In terms of management of rosacea, prevention is by reducing or eliminating triggers such as alcohol and caffeine. Topical treatment options include metronidazole, ivermectin, azelaic acid, while antibiotics such as erythromycin topically are less effective. Now, in terms of systemic treatment options, these include oral antibiotics such as minocycline, doxycycline, and metronidazole, oral isotretinoin, as well as oral ivermectin. For patients with telangiectasia, you can offer oral carvedilol, which is a beta blocker, topical brimonidine, intense pulse light, vascular laser, as well as electrodesiccation. For patients with rhinophyma, they may benefit from laser treatments, radiofrequency, or even surgery. And with that, we have covered acne and rosacea, and I thank you for your kind attention. Have a nice day.